Everything okay? No problem, just having a heart attack. Almost over. Done. Very good.
Hi, this is Chris Kadursky, Anna Abrams, and Boone Lawrence, and our presentation is on cardiogenic shock. You just saw a video from Saturday Night Live with superfans of Chris Farley going into a heart attack. And you're going to see that heart attacks do play a major role in cardiogenic shock. But before we get into cardiogenic shock, we need to understand what shock is. And shock is the inadequate perfusion of cells, tissue, and organs with oxygen and other nutrients such as glucose, resulting in cell, tissue, and organ dysfunction. It is also known as hypoperfusion. Okay. The etiology of shock. Now, there's three reasons why shock can happen, and it's inadequate volume, inadequate pump function, and inadequate vessel tone. And you can see here within the picture, it's just a very condensed view, but the volume is on the bottom. That is the amount of blood and plasma within the circulatory system. The pump is the heart itself, and the vessel tone is the shape and the size of the arteries, the veins, the capillaries, the arterioles, etc. Now, inadequate volume is a decrease in blood volume. The lack of blood volume decreases the preload of blood in the heart, causing stroke volume and cardiac output to fall. A decrease in cardiac output results in a drop of systolic blood pressure. Systolic blood pressure is responsible for transporting oxygenated blood throughout the circulatory system. Moving on to inadequate pump function, as already discussed, the pump is the heart. And the heart basically controls the cardiovascular system. And the amount of blood ejected by the heart in one contraction, that is referred to as stroke volume. Inadequate pump function in the heart is failing to generate enough force to move the blood throughout the body. If the pump fails, regardless of blood volume, the delivery of oxygen and glucose to the cells will decrease. And then finally, we have inadequate vessel tone. And that, as I discussed, or as I mentioned, that is the size of the vessel and the resistance created within it. So as resistance in the vessel increases, so does the blood pressure. Inadvertently, as the vessel resistance decreases, so does the blood pressure. To say it in a different way, as the vessel size increases, the resistance decreases, lessening the amount of blood that can reach the heart. So here is your pathophysiology of shock, and we're going to focus on primarily on the left side here. And this is shock due to the loss of oxygen, and it starts with going into anaerobic metabolism. Since we do not have oxygen, we're breaking down ATP using anaerobic metabolism. And you see how it branches off here onto the right, decreased energy ATP, and now we're going to pull sodium across the cells, and that's going to go into an influx of intracellular sodium and water. That decreases our circulatory volume, which activates the clotting cascade, one of our body's compensatory mechanisms. Also, it creates cellular edema, which ruptures the cell, creating an inflammatory response, which the cell dies, and it releases a digestive enzyme, limasol, which starts to consume the cells. So this starts a never-ending story, a vicious cycle that will run over and over and over again until it's corrected. Now, cardiogenic shock is a state of critical end organ hyperfusion due to reduced cardiac output. So that means a part of the heart, the muscle, is dying because it is not getting enough oxygen and glucose to it. And symptoms of cardiogenic shock is a systolic blood pressure under 90, pulmonary congestion, decreased urine output or no urine output at all, altered mental status, and cold, clammy skin or extremities. And as we follow cardiogenic shock, okay, we're going to see that it is a downward spiral. So it starts, and then things start to cascade, they compound on each other, and they go down to the end, which ends in organ failure. And organ failure can end in multiple system failure, MODS, and eventually death if it is not stopped with medical intervention. So if we're going to look at the pathogenesis of cardiogenic shock, shock happens, and it usually can happen from a heart attack. We have decreased cardiac output. The output also decreases stroke volume. And this sets off a multitude of things and reaction, setting off hormone releases, the body's compensatory mechanisms, okay? And in this case of shock, those mechanisms do not play in our favor. They work against us. So they try to increase blood volume, but it results in a decrease of blood volume, and it increases the preload and the heart rate, trying to increase stroke volume, and it keeps working its way down, and the body cannot do this. So it will come eventually to decreased tissue perfusion and impaired cellular metabolism. And once that happens, the cell, then it bursts, it dies, it releases the enzymes, and it starts to attack other cells. All right, so now that we have a basic or rudimentary understanding of shock and cardiogenic shock, you're going to see a brief scenario of how a myocardial infarction or a heart attack plays a role in cardiogenic shock and how it can be treated in the field environment and what can be done at transportation and the methods of transportation needed and where to go once it is determined that the cardiogenic shock may be a factor. You're dispatched to 1002 Highland Street in Haddonfield. Patient is in his mid-70s and is complaining of chest pain and shortness of breath. Says the symptoms came on suddenly and that he's extremely tired from stalking the same girl for 42 years.
About 2 copies, show us en route.
Hi, sir. All right, scene is not safe currently. Sir, do you think we can put that knife down so I can take a look at what's going on? No? Could I hold the knife for a minute? Thank you. I know, you can have it back in just a minute, okay? I just gotta check you out here. Can you tell me what's going on? I heard you have some chest pain. Yeah? Okay, well, we're gonna take a look at that. I'm gonna turn on this monitor. I'm gonna have to place some stickers on you to take a look at your heart. Is that okay? All right. I'm gonna take your hand over here. I'm gonna have to take this off so that I can get those stickers on. Do you think you can help me move this arm out of here? Thank you. Almost. Can you bend that arm, maybe? There we go. your medical history, do you have a history of anything else? Do you have a history of diabetes? No? Okay. What about smoking at all? Do you smoke or have you smoked? Yeah. How many packs do you smoke? Do you smoke more than 1 pack a day? 4? Okay. And I noticed it seems like you're having a little bit of difficulty breathing, yeah? A little shortness of breath. And it looks like you have a high heart rate. We've got about 144 beats per minute there. And then what about any other health issues? Have you ever been diagnosed with diabetes? Okay, what about anything like low or high cholesterol or anything? Yeah, okay. Gotcha. Well, we're gonna get a good look at your heart here now, and then we'll get you put in the ambulance here pretty soon. You're not responding totally the way we'd like. Do you feel lightheaded or anything like that? Yeah, okay. That's probably because of the oxygen levels. So we'll get some oxygen on you soon. I'm going to take a quick listen to your lungs too, okay? Alright, so I'm going to take a big deep breath in. Alright. So with that, we do hear diminished lung sounds. We hear some crackles in there. So I'm starting to get an idea of what might be going on, but I'm going to have my medic come in here soon also. I'm just going to take a feel of your skin. Yep, it's a little clammy. Your hands are cold. I'm going to take a quick peek at everything else too. Just make sure you're not feeling weird anywhere here. I'm going to feel your pulse. Alright. Yeah, your pulse is a little weak also. And irregular. Alright, you stay with me, bud. Alright, I just have a couple more questions for you. Have you been eating normally? No? Okay, have you been able to stay hydrated, drinking water? Okay, what about your urine output? Has that been normal? Or just a little bit? Oh, okay. You have it in a bottle for us. That is very helpful, thank you. And how long has this been for? Has it been a day or 2 days? 1 day? Okay. Alright. Well, I think we might be having some heart issues. We're going to take a look at the 12 lead in just a minute here. But we'll get you in the ambulance and get you treated and on to a hospital, okay? Okay.
Management of patients in cardiogenic shock can be very different depending on the cause of the patient's condition. By far the most common cause of cardiogenic shock in adults is acute myocardial infarction. We've intentionally divided the assessment portions and the treatment portions of this to make it a little bit more clear. The first priority is to prevent the clot that's formed in the heart from getting any worse. So often when a patient presents with chest pain and we suspect it's cardiac in origin, we'll administer aspirin immediately. What aspirin does is it inhibits the ability of the blood to clot. And we'll give 325 or 324 milligrams orally of baby aspirin, have them chew it up and swallow it. Then, like we already did, we ran a 12 lead. Now, let's say this patient presented with ST elevation myocardial infarction. At that point, there are some treatment options. We are not going to be able to provide this patient with definitive care in the field. One of the next things to consider could be a drug like Brilinta. Brilinta is basically like a heavy-duty aspirin and will act a little bit longer to further prevent that clot from progressing and getting worse. Our next goal in this case is going to be to reduce the workload on the heart. So what's happening is there's a clot in one of the coronary arteries, and part of the heart isn't getting enough oxygen. And that is what's causing the heart to not pump blood as effectively as it should. Just treating your patient based on some of their presentation, for example, we're seeing this patient not have adequate oxygen saturation. So we're going to apply oxygen at whatever rate and by whatever means it really takes to get the patient up to that target of 94 to 98%. Reducing the workload on the heart is going to be important. The heart doesn't have enough oxygen, and if we're putting a lot of pressure against it, that's only going to make it worse. The body has some compensatory mechanisms, but they're surprisingly bad at compensating for cardiogenic shock. One of the things that it's going to do is utilizing a system called the RAAS system. It's going to release a series of hormones that's actually going to constrict the vasculature. The only thing that your body knows is that your blood pressure is dropped. And its only way to combat that is to constrict the vasculature and turn up the heart. So it releases these hormones that will have ionotropic effects and increase the contractility of the heart, and also cause the arteries to constrict. We already have a heart that's having a hard time pumping, and basically what we're doing is putting more pressure on it. That isn't necessarily going to increase the perfusion of the heart itself. So all we're doing is increasing the oxygen demand of the heart muscle, and that really is not what we want to do. So some things we can do to combat this is we can give things like nitrates. These will have to be used with caution. For example, this patient's blood pressure is low. We would not want to give this patient nitroglycerin with his current systolic blood pressure. However, if his blood pressure was elevated, that would indicate that there is a lot of back pressure afterload on the heart, and that's a lot of work that the heart has to do on diminished oxygen supply. So if you were to present with higher blood pressure, we can give nitroglycerin to try and relax that vasculature and reduce the amount of work the heart has to do to push blood out of it. The other effect that nitroglycerin can have is actually opening up that artery on the heart that's clogged. And if that can open up just a little bit, maybe a little bit of blood can get by it and start to reperfuse that heart tissue and maybe give us a little bit more time. Another thing to consider is the sympathetic nervous system response to this. So that's going to be activated partially by the drop in blood pressure, and also partially by the pain that this patient is in. If he's experiencing a significant amount of chest pain, which he is, we should consider giving an analgesic like fentanyl, for example. Fentanyl is generally pressure supportive, so even with his lowered blood pressure, we could consider giving some fentanyl. What that can do is decrease, again, that sympathetic nervous system response, which is trying to further constrict the vasculature, and it's trying to crank up that heart rate and the work that the heart's doing. And by giving that fentanyl, it's not just for the comfort of the patient, it's it can have a physiologic effect of not of reducing the work that the heart's having to do. Again, ultimately, we're not going to be able to provide definitive care for this patient in the field. Once we've determined that this patient is having an MI, our our destination choice is going to be critical. Depending on the hospitals that are available, this person is likely going to need PCI, percutaneous coronary intervention. He's going to need a stent, most likely. He's going to need a cath lab. If we cannot get him to a cath lab within 90 minutes, he might benefit from stopping off at a local facility to maybe get some thrombolytics going, and then be transferred to a higher level of care. But ultimately, if you can get him to a cath lab in that 90-minute window, that's what needs to happen. That's what we're going to do now.